Hey, welcome to the IPHAM seminar series. My name is Adela Mizrachi. I am the communications manager at IPHAM. This is a joint presentation between IPHAM and NUCATS, and we're really excited to welcome the team from the Mothers and Babies program. I'm going to just before we start, I want to let everybody know that we're going to take questions and answer. We're going to do the Q&A at the end. But as you have your questions, feel free to pose them. Just be sure to use the Q&A panel at the bottom and not the chat. We won't be monitoring the chat for questions and answers. We'll be using the Q&A. So on that note, I want to welcome the team from the Mothers and Babies program. I'm going to introduce the lead investigator of the program, Darius Tandon, who is an associate professor here at Northwestern. He's also the co-director of the Center for Community Health at IPHAM, and he's going to introduce his team. So I'll hand it over to Darius now.
Thanks, Adela. So really delighted to be here today and be able to share a lot of work with all of you that we are doing with our Mothers and Babies program. And we've intentionally decided to have multiple presenters today, really reflecting the team approach that we take. So I have my colleagues Jessica Johnson, Alicia Diebold, Jaime Hamil, and Erin Ward who are presenting with me today. They are respective team leads on projects, and you'll be hearing from them as they are later in the presentation. So we have nothing to disclose. And what I'm going to do is start by giving folks an overview of our Mothers and Babies intervention, a little bit of the rationale for why we are doing our work, a little bit of our previous research that we've conducted, and then I will then transition over to my colleagues who will be talking about work that we are currently engaging in. So I think it's really important for us to just start with this orienting slide to give folks a sense of, our philosophy with our Mothers and Babies work, which is a mental health intervention. We believe as a team that mental health services and supports need to be widely available, easy to access, affordable, non-stigmatizing, and effective. So these are really the guiding principles behind our work. And what you will see is many of our approaches, many of our research studies are really trying to address these issues to be able to provide more services and supports to pregnant women and women with young children. So a little bit about the Mothers and Babies intervention. For those of you who are not familiar with it, it is a manualized intervention based on principles of cognitive behavioral therapy, CBT, and attachment theory. We've done quite a bit of research examining the effectiveness of the intervention, and we know that the intervention is effective in reducing depressive symptoms as well as preventing new cases of depressive episodes among perinatal women. A couple of years ago, the United States Preventive Services Task Force did a review of interventions aimed at preventing postpartum depression and cited Mothers and Babies as one of the two most effective interventions for prevention of postpartum depression. And later on in the talk, you'll hear Erin Ward talk a little bit about how that U.S. Preventive Services Task Force report has really led to an uptick in interest that service providers have had around the country for the Mothers and Babies intervention. Even though we are a depression prevention intervention, we know there's a lot of stigma around the word depression. So we really frame the intervention as a stress reduction intervention. And we'll talk a little bit more about that in a minute. So this is a really important slide in that if you look at the bottom figure, you see this triangle, and on the far right, you see this diagnosed depression, and those would be women who have major depression or clinical depression. And that group of women really is about 10 to 15% of women that we know have diagnosed cases of clinical depression. But we also know, and this is sort of the bigger band where we say mild to moderate depressive symptoms, we also know that 30 to 45% of women have elevated depressive symptoms. And the reason that that is important is that is a population that is that is at high risk for developing episodes of major depression. So that is a group that we are really working with intensively in our intervention work. We know that perinatal depression has a two-generation effect, meaning that depression in mom not only affects mom in the ways that we've listed here on the slide, but it also affects their children. So children of depressed mothers exhibit poor birth outcomes, higher rates of abuse and neglect, less readiness for school. So we really believe that intervening with moms has an effect both on maternal mental health, but also on child health and well-being. We do a lot of our mothers and babies research in the context of home visiting programs, and I don't expect that everyone attending today is familiar with home visiting programs. So this is a very high-level overview of what they are. So who do they serve? They serve expectant mothers and new mothers. When do they provide services? They provide services in the prenatal period and the child's early years. Why do they exist? They really exist to promote maternal and child health outcomes among high-risk families. And there are a variety of professional and paraprofessional models. So there are about 20 so-called evidence-based home visiting models that through rigorous evaluation have determined to be effective in improving a host of maternal and child health outcomes. Home visiting exists in every state around the country. Much of it is funded through the Maternal Infant Early Childhood Home Visiting, or MICV initiative that was initially funded through the Affordable Care Act. There's also state and local funding that is given to home visiting programs. And a reasonable estimate is that over 750,000 families are served per year via home visiting. So it really is a nice opportunity to provide services and supports for a large number of perinatal women. In terms of the integration of mothers and babies into home visiting, we've developed mothers and babies to be an intervention that is model agnostic, meaning that regardless of the home visiting model that a program might be using, and some of the more familiar home visiting models are Parents as Teachers, Healthy Families America, Nurse-Family Partnership, regardless of the model, mothers and babies is something that can be integrated into those different home visiting models. And what's the reason for doing integration of mothers and babies into home visiting? Well, we know that the current model for most home visiting programs is to do a depression screen and then do an external referral to a provider if somebody is exhibiting elevated symptoms or major depression. But we know that there are a number of barriers that exist to home visiting clients accessing those external mental health resources, and we've listed some here. Additionally, and this is the second bullet point at the bottom, most home visiting programs really focus just on women who need depression treatment. So if you go back to that earlier slide, it's that 10 to 15% who are diagnosed as having major depression. But we know, as I said earlier, that those women who have elevated symptoms are both at risk for developing major depression, but also elevated depressive symptoms have many of the same impacts on maternal and child health outcomes. So a reduction in depressive symptoms in that population is also potentially impactful. So a little bit about our mothers and babies intervention. So we have two intervention modalities. The first is a group modality, and we've done multiple randomized control trials to demonstrate the efficacy and effectiveness of the group modality. Recognizing that there are challenges to doing group-based interventions, so challenges around transportation and childcare. A few years ago, we developed a one-on-one modality of mothers and babies and have done research to demonstrate the effectiveness of the one-on-one modality as well. And at the bottom, this little table just shows you the major distinctions between the group and the one-on-one modality. So the group modality has 6 sessions. Each session lasts about 90 minutes, and there are multiple women from a home visiting program that would be part of a mothers and babies group, whereas the one-on-one version of mothers and babies is 9 sessions, and each session lasts 20 to 25 minutes. Just a little bit about the intervention content itself. So we have an instructor manual, which is used by those who are delivering the intervention. We have a participant manual that is used by the families or clients that are receiving the intervention. All of those materials are publicly available on our website, which is listed here. And we are fortunate that we've received funding to be able to translate the materials into multiple languages, including Spanish. I won't go through this, but the one-on-one and group intervention really follow the same format in that there are 4 modules. There's an introductory module, which really tries to identify stressors that a perinatal woman is experiencing and understand the relationship between those stressors and their mood. And it also introduces the 3 mothers and baby modules, which are pleasant activities, thoughts, contact with others. So those of you who are familiar with cognitive behavioral approaches, this will look very familiar. Pleasant activities, thoughts, contact with others are sort of CBT components. And again, both the one-on-one and group modality of mothers and babies go through the intervention, starting with the introductory module and then pleasant activities, thoughts, and contact with others. So a little bit about the structure of each session, and this is, again, is true both with the one-on-one and the group modality. There are a number of topics within a mothers and babies session, and each of those topics has some key points, which are the main messages. There's also a script which we provide to the facilitators that we say you do not have to use the script word for word. It's a roadmap, but really intended to provide guidance for facilitators on what to deliver. The intervention is intended to be highly interactive. So we have interactive learning activities throughout each session that engage in discussion between the facilitator and client. And then there are personal projects. So think about homework assignments that clients are asked to do between sessions to really reinforce and build on the skills that are talked about during the intervention sessions. This is just a snapshot of a couple images and activities that are in the manual. So on the left-hand side, you see these 2 seesaws or teeter-totters, and on the top, you see this idea that different stressors in your life can affect your mood and bring your mood down. And at the bottom, you see that on the right-hand side, you've got healthy behaviors, healthy thinking, supportive people, which are really the core ideas behind mothers and babies that are intending to balance out the stress. So that's an example of an activity that a facilitator would go through with a client. On the right-hand side, you see what we refer to as our quick mood scale. And the quick mood scale is intended to be a tool that clients use to identify what their mood is and also identify what things are going on in their life that might be causing their mood to be average, above average, below average. So again, this is just intended to give you a snapshot of a couple of the ideas and a couple of the core activities in the introductory module. So synergy between mothers and babies and home visiting. So I talked earlier about how many home visiting programs, if they don't have mothers and babies, are really reliant on external referrals to mental health providers or primary care providers. But mothers and babies really builds the capacity of home visiting programs to address mental health internally. We also know that for federally funded home visiting programs, mothers and babies is an approved source of a completed depression referral. So it meets the benchmarks or milestones for these federally funded home visiting programs. Mothers and Babies is low cost. It also builds on the relationship between home visiting programs and clients to introduce content related to mental health. And we also know that depression is a challenge for home visiting programs. Depressed mothers, whether it's clinical depression or elevated symptoms, these are women who may not stay engaged in home visiting as long as other women. So by addressing mental health, we think that we're providing an avenue for home visiting programs to also be able to more fully engage with their clients. So my last slide before I turn it over to my colleagues is intended to sort of tee up the rest of our talk. So what we're going to be doing today is providing a sampling of some of the work that we are doing. And this is not actually the entirety of our work. So there's a lot going on in our research program. So my colleague Jessica Johnson is going to first be talking about a PCORI-funded study that has as its central question whether lay home visitors can generate similar outcomes as mental health professionals when delivering the intervention. My colleague Alicia Diebold is going to talk about a recently funded R01 that is taking a look at the longer term impact of mothers and babies on parenting and child self-regulation. Jaime Hamil, who is one of our team members, who is also working on her PhD right now at the University of Illinois at Chicago, She is going to be talking about two of our studies that are actually funded through the same NIMHD R21. The first is around improving fathers' mental health, and the second is using text messages as a reminder to improve mothers and babies skill practice. And then finally, my colleague Erin Ward is going to be talking about how we have been promoting the scaling and the replication of mothers and babies while trying to maintain intervention fidelity and impact. So with that, I'm going to turn it over to my colleague Jessica, who's going to be talking about our PCORI funded study.
Good afternoon, everyone. Thank you, Darius, for the introduction. As Darius mentioned today, this afternoon, I'm going to address the question, can lay home visitors generate similar outcomes as mental health clinicians when delivering group mothers and babies? So our previous research has established the effectiveness of mothers and babies in preventing new cases of postpartum depression and reducing depressive symptoms when led by a mental health clinician. Previous research also has compared the delivery of CBT interventions between professionals and lay health workers to treat depression and anxiety. However, to date, there have been no published studies in the United States examining lay health workers to prevent depression. Our study had 4 aims. First, we wanted to compare the effectiveness of MB group when led by a lay home visitor to usual home visiting services, and this was our superiority aim. We then wanted to compare the effectiveness of MB group when led by a lay home visitor or a mental health clinician, which was our non-inferiority aim. We also evaluated whether effectiveness of these two versions of mothers and babies group varied according to our participant characteristics. And then lastly, we wanted to examine the feasibility and acceptability of MB group when delivered by both of these types of facilitators. So we ended up recruiting 45 home visiting programs across 7 states in the Midwest, including West Virginia. We then randomized these programs into one of 3 study arms: mothers and babies delivered by a lay home visitor, mothers and babies delivered by a mental health clinician, and usual care, which was our control group. A woman was eligible to participate in our study if she was 16 years of age or older, she spoke English or Spanish, and was 33 weeks or less gestation upon referral. We ended up enrolling 874 pregnant women into our study. 405 of these women participated in mothers and babies groups facilitated by a home visitor. 310 participated in groups facilitated by a clinician, and the remaining 159 women continued their usual home visiting service without mothers and babies intervention. We do believe that a major strength of this study is its inclusion of a racially, ethnically, and geographically diverse set of participants. Here just gives you a very high-level snapshot of some of our demographics. So the mean age of our participants was 26 years old. 70% of the women in our study were part of a racial ethnic minority group. 36% identified as first-time moms, and the average weeks gestation at enrollment was 23 weeks. We ended up conducting 132 cohorts, or 6 weekly mothers and babies groups, over our study timeline. These cohorts had on average 3 participants and on average lasted around 86 minutes. We did collect maternal self-report surveys via REDCap at various time points. So at baseline, when our moms enrolled into the study, post-intervention, and 12 and 24 weeks postpartum. Depressive symptoms at 24 weeks postpartum was the primary outcome controlling for baseline symptoms, and we assessed this using the Quick Inventory of Depressive Symptoms scale. We also assessed fidelity, so we did end up audio recording all of the 132 mothers and babies groups. We then randomly selected a 20% sample of those recorded groups to be able to assess facilitator adherence and competency. We developed a modified version of the revised cognitive therapy scale, which we called the MBCTS, to be able to assess adherence, so how well the facilitator was delivering the intervention according to our instructor manual, and then their competency, so how skillful they were in delivering the intervention. And then you may remember from the AIM slide, our fourth aim was to look at acceptability and feasibility. So we did conduct semi-structured interviews with all of our facilitators and a subset of our participants. And these interviews asked about both facilitator and participant experience with mothers and babies. And we audio recorded these, transcribed, coded, and thematically analyzed them using in vivo software. So what did we find? We did find that neither intervention arm was superior to usual care in decreasing depressive symptoms across the entire sample. However, even though we weren't able to claim superiority of mothers and babies to usual home visiting services, our post hoc analyses did suggest a positive intervention effect for a subset of women entering into our study with mild depressive symptoms. So going back to that first question that we were looking at, so can lay home visitors generate similar outcomes as mental health clinicians when delivering mothers and babies? Yes, we did see evidence of non-inferiority as mothers and babies delivered by both home visitors and mental health clinicians did yield similar reduction in depressive symptoms. We also found that home visitors did deliver mothers and babies with similar adherence and competency as their mental health clinician counterparts. And facilitators and participants alike found MB acceptable and appropriate when delivered by either a home visitor or a mental health clinician. So what does this all mean? So this study does provide data to suggest that home visitors can deliver mothers and babies with similar fidelity and generate similar outcomes as mental health clinicians. We do think that the lower baseline depressive symptoms among the study participants in this study compared to in our previous MB trials may have contributed to that overall superiority finding in this study. And then lastly, today, I did want to address this idea of task shifting. So shifting responsibility for delivering interventions such as mothers and babies from the mental health clinicians to lay home visitors, as this option is very economically viable. So in most cases, home visitors are already salaried by their agencies, so we wouldn't need to bring in an external mental health clinician that would add additional payment to facilitate a group-based intervention like mothers and babies. So this study really suggests that lay home visitors may be a viable resource to be able to deliver PPD preventive interventions within home visiting, and as such really allows for the delivery of mental health services outside of this public mental health system in both a feasible and cost-effective manner. So thank you. I'm going to turn it over now to my colleague Alicia Diebold, who will talk about our EPIC study.
Thanks, Jessica. Good afternoon. I'm Alicia Diebold, and as Jessica mentioned, I'll be presenting on the EPIC study today. So our EPIC study builds on the MB group study that Jessica just presented on to look at longer-term outcomes of MB on parenting practices and child self-regulation. So as a little bit of background, based on the literature, we know that perinatal depression is a strong predictor of poor parenting and disrupted child regulation. Most interventions target children already exhibiting behavioral challenges and do not focus on the mother's skills for regulating their thoughts, emotions, and behaviors. The basis of this study is really grounded in the idea that cognitive and emotional skills found in the MB intervention that equip women against perinatal depression may also equip them to be more responsive, positive, and child-centered parents. There's also been few studies that have examined the potential moderating role of paternal variables. So I just wanted to mention that there's innovation in this study and that the intervention is delivered prenatally, which was part of our MB group study, and in examining the father's role in moderating the relationship between maternal depression and maternal parenting and child development. So we'll look at that a little bit more in the next couple slides. So here you can see we have 3 study aims. So aim 1 is to examine whether targeting perinatal depressive symptoms with MB prevents disruptions in well-regulated parenting and child self-regulation. Aim 2 examines the extent to which improvements in core cognitive behavioral therapy skills mediate improvements in parenting and child self-regulation outcomes. And our third aim is to examine the extent to which identified variables moderate MB's preventive effects on maternal parenting and child self-regulation. So I won't spend too much time on this, but I did want to share our conceptual framework today. So at the top, you can see here our aims 1 and 2 with our specified mediators, as well as our parenting outcomes and child outcomes. And at the bottom there, you can see our aim 3, which has our moderators of intervention effects, which includes our father and paternal variables, including father's mental health, father's involvement with the child and quality of parenting, and father-mother relationship, as well as a few sociodemographic variables that we wanted to look at, including minority race, ethnicity, lower socioeconomic status, and adolescent motherhood. So for this study, our target recruitment goal is 720 female participants, which includes 480 women who received the MB intervention as part of the MB group study, and 240 control participants. We're also aiming to enroll 360 father or other caregiver participants. The eligibility criteria for all of our participants is that they're at least 18 years old and speak either English or Spanish. And for our female participants, there's added criteria that they have a child who will be 30 months old by the end of December 2021. And for the father participants, that they have a relationship with a child of one of our female participants. Data will be collected through REDCap via self-report assessments at 5 time points for our mom participants. So when her child is 30, 36, 42, 48, and 54 months. And for our fathers, it's at 3 time points when the child is 30, 42, and 54 months. We'll also be doing observational assessments with a subset of our participants at 3 time points when the child is 36, 42, and 48 months. So this gives a quick snapshot of kind of where we're at to date. So we have 751 participants enrolled in the study, which includes 358 intervention participants, 167 control participants, and 226 fathers. You can see there are survey completions, which we're moving along. We're anticipating sending out our first 48-month survey next month. And our plan is to have our data collection completed by the end of January in 2024, with the study being completed the end of June of 2024. So I did want to note that, unsurprisingly, we've had a few challenges we've run into due to the COVID-19 pandemic. One of the biggest challenges we faced was with our observational sub-study, which was initially intended to be done in person with study participants. So we've had to make some pretty substantial changes to our protocol in order to conduct these assessments virtually. But I'm pleased to say that we'll be starting this part of the study this month. Another challenge has also been in relation to our participant recruitment. So as Darius mentioned, we do a lot of our recruiting through home visiting programs who are currently experiencing their own challenges with engaging families. And lastly, given the added stressors families are facing, we've been cognizant of our participant retention and engagement. So a couple of things we have done is working on our communication with participants, including sending newsletters with timely resources and being understanding of competing demands that families have right now. We've also added an additional survey to collect data on how COVID is impacting the lives of our study participants. So for this, we've used questions from the Coronavirus Perinatal Experiences Impact Study and Impact Update. So that's all on the EPIC study today. Thank you for your time, and I'm going to turn it over to Jaime Hamil.
Thanks, Alicia. Can everyone hear me? Great. So I'm Jaime Hamil. I'm going to be talking about our Mothers and Babies text messaging project, as well as our Fathers and Babies project as well, to kind of build off of what Jessica, Alicia, and Darius have already shared with you. So despite that we know that there's effectiveness with our Mothers and Babies intervention, we still see participant variability with the effects of the intervention. So we really wanted to examine these mediators and how we could improve the effectiveness or kind of enhance the effectiveness of the Mothers and Babies intervention. And so we really explored this option by using mHealth, so using SMS text messages to kind of augment this intervention. And this was in collaboration with our colleague at Palo Alto, Dr. Alin Barrera. She had developed text messages for the Mothers and Babies intervention. And so we collaborated to really look at how we could test the feasibility and acceptability of using this in our one-on-one intervention. So this was done with mothers and babies one-on-one, so not the group. I know we have some modalities. And so these text messages were created to augment the mothers and babies intervention impact. So really these mediators were focusing on the behavioral activation, which is the pleasant activities, mood regulation, which is our thoughts, and social support, which is our contact with others. These text messages really did skill reinforcement, homework reminders, which Darius talked about, those personal projects, as well as some self-monitoring. So really checking in about the mood, how their mood is, as well as, how are they using these activities, such as typing in a pleasant activity. So again, we really wanted to focus on, if we started to use these text messages to augment the mothers and babies one-on-one intervention, is this feasible and acceptable? And what do our preliminary outcomes look with our mental health outcomes? So these were delivered in home visiting programs. This was a quasi-experimental study. We actually engaged 9 programs throughout Illinois, representing rural and urban areas. We had 2 study groups. So one was just receiving mothers and babies one-on-one as usual, as my colleagues have described. And the other was mothers and babies one-on-one with text messaging. So again, this was a small pilot study, about, around 30 in each arm. So what the mothers and babies text intervention is you get the participants would get the mothers and babies one-on-one during their regular home visiting. And then after each session, these automated text messages to, again, reinforce what they've learned, do the self-monitoring and the homework reminders were deployed using our Healthy SMS system. So there were 3 text messages per session. This was done with actually our 12-session mothers and babies. This was before we condensed it to 9 sessions. So they received a total of 36 messages over the course of the 12 sessions. And these messages were triggered in our Healthy SMS platform, which was a collaboration with our colleague, Alin Barrera, who had been using this in previous work. Next slide. So overall, we did have a racially and ethnically diverse group of women that received mothers and babies or mothers and babies text message. Again, this is just an overall sample, what it looked like. Our average age was about 24. We had about 43% of the women that identified as Black and African American, and about 36% that identified as Latinx. Our average gestation week at enrollment was about 26 weeks. So this study was done with prenatal women. Our data collection focused on the effectiveness of the MB text, so really looking at these maternal self-reports around mental health. And we collected data at 3 months and 6 months. We also really focused on the feasibility. So this was assessed after each session to really understand how feasible it was to implement MB text using Healthy SMS, and how participants were finding this acceptable. So did they enjoy the messages? Did they find them useful? And were they understandable? So overall, we had some exciting findings. Although we didn't see a difference between groups from the MB one-on-one to the MB plus text messaging with the outcomes, we did see a change over time for our MB text participants that was statistically significant. So we did see a change in their depressive outcomes, which is really exciting to kind of see that in our preliminary study. I think very excitingly, we really found out that participants really enjoyed the text messaging, that even though we may not have seen the movement in between one-on-one and text, they really thought that the text messages were useful, that they were understanding them, and that they were enjoyable. A lot of participants really said, I got the text messages just in time. They really helped me. They were in the moment of stress, and I remembered I needed to do a pleasant activity. So this was very exciting for us. Overall, the home visitors did really enjoy this, but there were some areas for improvement to make this more useful for them. So we have been working with the home visitors and getting feedback to really understand how we can improve using Healthy SMS. They have busy schedules. They're not always there on their computer or phone, as you know, before when they were doing this, they were actually physically going to participants' houses. So how can we kind of build that to improve triggering these messages post sessions? So for conclusions and future directions, again, we found that home visitors and clients really thought that this was a useful way to kind of enhance the mothers and babies intervention. We need to improve how we can better remind and work with home visitors so that they can use the Healthy SMS system in a more manageable way that works for them. And that we are seeing that there are statistically significant reductions in the depressive symptoms for our MB text arm. And again, we really are looking at how mobile health technology can really help enhance the mothers and babies intervention and really guide some of our future work to include this in other areas that we're examining. So next, I'm going to talk about our fathers and babies intervention as well, which was developed in collaboration with Craig Garfield. I saw that he was on, so I wanted to give him a shout out. So as kind of Alicia mentioned, is we are really interested not only in maternal mental health, but paternal mental health as well. And we've really kind of looked at this and saw, 10%, the prevalence of paternal depression is estimated about 10% during the perinatal period. And so that there is something, an impact on father's mental health as well. And as we kind of dove into this work, we really realized that there were no interventions that focused specifically on paternal mental health. It was really focused on parenting, but not this mental health aspect, which we know is very important, especially as Jessica mentioned and Darius, that we know that parents' mental health impacts our children. And so how can we ensure that both parents are equipped with these skills to manage mental health? So what we did to develop the Fathers and Babies program, initially we consulted, of course, with the literature, our fatherhood experts such as Craig Garfield, as well as our infant mental health consultants to kind of really guide what our focus should be on as we develop this intervention. And with these kind of contours and recommendations, we then conducted focus group with home visitors, home visiting clients, and the fathers or partners of these home visiting clients. So these were actually home visitors that were delivering mothers and babies, were familiar with it. The moms had received mothers and babies, and then their partners had also known about mothers and babies because they had been enrolled in the home visiting programs. So again, we had two goals that came from this focus group. One was to focus on father's mental health and to support his partner's mental health and to really make the intervention flexible and accommodate schedules. So we also developed this to be with our Healthy SMS technology as we were doing the pilot. So the FAB sessions, and that's what we call it, the Fathers and Babies Intervention, FAB. We like the title. We think it sounds nice. Our fathers like it as well. To be delivered in concurrent with mothers and babies. So this really was developed to, as mom was receiving mothers and babies during her regularly home visits, that dad could also receive fathers and babies. And so the first session was always done with both mom and dad. Over the phone or in person. So if dad couldn't attend, the home visitor would then schedule a time to speak with dad to really talk about, why are we doing this? What is fathers and babies? What is mothers and babies? What are the goals? And then subsequent sessions could either be delivered at the same time as mom was receiving mothers and babies, or it could be delivered as mom was receiving mothers and babies in person, and dad could receive everything via text. So these would link to content, worksheets, everything, so that dad could actually receive the intervention at his own schedule and could accommodate any kind of scheduling conflicts with the home visits. Or they could be kind of done home visit or in person and text messaging. So a few ways that could be done. So an example of this content, as Darius kind of points out in our session 3, which is our pleasant activities module, we kind of identify types of pleasant activities that can help improve mom's mood. And so this is also done to help improve father's mood. So what are some activities that dad can do for himself to improve his mood? What can he do with his partner? How can he support his partner? But also what can he do to also engage in a pleasant activity with baby? So all of the content is aligned with the mothers and babies intervention. So we actually just wrapped up our pilot testing in the fall of 2020. So it's been very exciting. We pilot tested with 30 father and mother dyads, predominantly African-American and Hispanic dyads, and a variety of relationship status. So these parents could either be married, they could be living together, they didn't need to be living together, but they could also just be co-parenting and not in a romantic relationship. So a lot of flexibility to really kind of mirror modern relationships and how those look in our family dynamics. We did a pre and post study design with this study. So again, it was just assessed mothers and dads pre-receiving the intervention and then after they received the intervention. So there was no control study. So that's also important to, or control group. So that's important to mention. And we also, so we collected data with our mothers and fathers at baseline 3 months and 6 months. And then we also did post-intervention surveys to really kind of assess acceptability and feasibility among moms, dads, and home visitors. And our outcomes really focused on maternal and paternal mental health outcomes. We use semi-structured, sorry, Darius, we use semi-structured interviews after the completion to really understand what the benefits of FAB and also recommendations for the revisions of FAB. So as we are on this slide, we did mixed methods. So we collected both qualitative and quantitative data. From the qualitative data, which I'll highlight, these are just some quotes from our dads. This, I think, was one of the most rewarding parts of our study, was just to really understand how fathers perceived fathers and babies, what they thought the benefits were, besides just looking at the numbers. So it was really nice. As you can see, one dad said it really helped me with stress and my mental health. Said it really helps you think about a young baby's future, your own future, your partner's future, and it helps you to think not only what is for babies and fathers and mothers, but it's broad, it's for everybody. So dads really felt that this was something for them, that there wasn't really anything from that for them, and they were really excited to participate. And most of them, or a few of them, have asked if they could be alum of our fathers and babies work. And actually, Darius has just kind of looked at our quantitative data, and we have some exciting kind of preliminary findings as well, is that we did see statistically significant decreases in perceived stress among both moms and dads at the 3-month follow-up and at the 6-month follow-up. So this is very exciting to kind of see that we are preliminary seeing this stress reduction and that it is really helping parents manage stress. We also saw decreases in depressive symptoms and anxiety symptoms among both moms and dads, but they are not statistically significant. So we're hoping to do some more research in this. So what's next for FAB? So based on our qualitative findings, we are now in the process of updating fathers and babies. So we are making revisions to align with our new 9 session. We are including some mindfulness, but also we are including this welcome packet. Dads really wanted some more information based on the pilot data, and that just as, you know, mom kind of gets this time with her home visitor, this welcome packet would provide a little bit more information to kind of ground what we're trying to do and the goals of fathers and babies. Currently, we're actually seeking support to help us expand this research and really examine the effectiveness of FAB on paternal and maternal health, as well as parenting practices and the dyadic relationship. So these relationships between mom and dad and how FAB and mothers and babies might kind of impact them positively. So I believe that's it. So I'm going to turn it over to Erin Ward to talk about our MB expansion work, which is really exciting. So thank you so much.
Thanks, Jamie. So I'm going to talk a little bit about what we've been doing kind of as a parallel process alongside all of our effectiveness and innovation research, and that is dissemination and implementation, really expanding access to the intervention and providing adequate resources so that it's done with fidelity so that we can ensure that the impact remains the same. So a little bit of background on how we have expanded. Darius already shared the great interest across home visiting programs, and that has continued to be the primary source of interest. We've also seen increasing interest outside of traditional home visitation programs across different healthcare settings, with increased recommendations to screen women during the perinatal period, so while they're pregnant, as well as during the postpartum year, to identify those at risk for postpartum depression. At which point we started receiving more inquiries about, once we've done this screening and we have, a woman who needs a resource, what do we do next if it's not someone who can be referred for a more formal mental health treatment? So to touch briefly on our training and implementation model, prior to COVID, we did in-person trainings. Those were typically 2 days in person or a day and a half, where we had the option to spend about an hour with a small group of supervisors and trainers. We've shifted our model this year to a virtual model, of course, where we're meeting over 3 half days, and we try to fit that within a 2-week time period. And pushing out the train the trainer session about a week after the formal training so that there's time to kind of absorb and process. Our implementation model involves consultation. So we consider this sort of like long distance group supervision, where we are interacting with implementing sites and staff as they're integrating this into practice. Darius referenced at the top of the hour the U.S. Preventive Services Task Force recommendation that took it another step, not only from screening, but from to provide preventive treatment for women who are at risk for developing postpartum depression. And in that recommendation, they highlighted 2 postpartum depression prevention interventions, one of which is mothers and babies. And the phone started ringing off the hook, basically. My inbox was overflowing. So this really spurred us to develop a more robust training and implementation infrastructure, expand the number of people who could provide these resources, and look more carefully at ensuring that we're really providing the resources to scale this, maintaining the effectiveness, and supporting the kinds of adaptations that may be needed to fit in different systems and settings. This slide is just to give kind of a shout out to all of the local and non-local funders who helped us along the way to provide training, to develop a website, to develop some supervision recommendations, and to engage with other stakeholders as we were starting to do more broad training. And I wanted to call that out because it's been an interesting funding landscape to figure out how to move from effectiveness research into dissemination and implementation, which is not the traditional NIH grant funding model. So at this point, we have trained over 300 individual programs and sites, the majority being home visiting, across 29 states. And the requests continue to come. So that really encouraged us to seek other funding, to expand our infrastructure with staffing and evaluation support, which takes me to the next step in the presentation, which is a new funding source, which is the Perinatal Fund. They are supporting the scale up of mothers and babies by enhancing our intervention infrastructure, supporting us in further developing an implementation toolkit, to really help with implementation and long-term sustainment. So not just within the year that we have a lot of contact with programs, but long after we've kind of backed out of the picture. And to really increase the amount of evaluation that we're doing in both the implementation and the impact. So a few details about how we are expanding. We've expanded staff. We are enhancing our website so that we're able to use this for scaling purposes, training purposes, and also to increase access. So we are going to be able to translate all of our materials into Spanish that aren't already. And a few other areas where we're really trying to attend to the multiple phases and stages of implementation. Where we're really trying to make sure that we are a good fit for the programs that are reaching out to us, and that we're really being thoughtful and intentional in all of these stages to set everyone up for success. So I'm just going to highlight a few tools and resources that we are developing for each of those stages. We've developed a pre-readiness survey, which folks will be able to fill out on our website. And that gives us an opportunity to see, who are you? What do you need? Is this one clinician? Is this a statewide network? So that we have a little bit more information when we're entering into conversations. We've developed an MB primer. So at a glance, all about the intervention, what implementation looks like. And we've been called on to host an MB town hall kind of at the outset of these collaborations so that providers have the opportunity to ask questions and learn more in advance of showing up for training day. Our implementation toolkit is where we're focusing a lot of attention this year and resources. I'm highlighting here our cultural adaptation of mothers and babies for use in tribal communities. We are hoping to have this out the door to disseminate in the next few weeks. And you'll see here we're also focusing on other intervention implementation resources that will help with using this in the field over the long term, both trauma-informed, developing a graphically designed participant workbook for those who have low literacy, and also some resources to develop our FAB intervention. In addition, we need help with training. So we are partnering to develop a virtual mothers and babies training refresher, with the idea being that folks who need to dust off their skills and refamiliarize themselves could access this. We can use it to kind of prep folks in advance of training. It can also be used as a tool for those who we have trained to train to integrate this into how they are sharing the intervention with others. In addition to this, we are beefing up our evaluation by not only doing training evaluations, but also looking at, on an annual basis, what does implementation look like? How much is this really, how many folks are implementing? How many clients are being reached? And are there particular successes or challenge areas where we could focus our support efforts? And at this point, I'm going to pass it back to Darius, who will talk about our next steps.
So thank you, team. Clearly a lot going on. So just one more slide, which is really to give folks a sense of where we see our work heading. And again, I think our North Star that we talked about earlier around availability, accessibility, affordability, and effectiveness are guiding all of this work. So the pandemic has accelerated work to examine virtual delivery of mothers and babies groups. We have some sites around the country that are piloting, and expect that we will pursue funding to examine this in a more systematic way. Also thinking about some of the non-responders to the intervention. Can we use just-in-time responses and adaptive trial designs to provide additional MB content to those women who may not be responding as favorably to the intervention? Additional scaling to specific populations. Erin referenced the tribal adaptations, but there are other settings that have reached out to us, military families, behavioral health, and how can we meet their needs? And then also developing and examining strategies to sustain the intervention beyond the initial implementation period. So I think that there are really important scientific questions that we should be looking at around proposing strategies to sustain mothers and babies. And then I think it's also important for us to think about how the relationships that we have with home visiting and knowledge of intervention delivery may allow us to examine other ways to promote maternal and child health more broadly. There's a newly released funding opportunity through NHLBI that is interested in promoting cardiovascular health among home visiting families, which is something that we intend to pursue. And then, let's be real here for a second. One of the major sources of stress for many of the families that we are working with relate to finances. And I think that there are some interesting questions that we should be looking at around income supports as a strategy for promoting mental health. So I don't want that to totally put us out of business, but I do think that the idea of providing income supports is a viable strategy that we should be looking at. So just to wrap up, want to show the rest of our team. The top line were the folks who were presenting today. I'm really indebted to everybody on this team. I love working with them every day, and they are so incredibly dedicated to the work. So thank you to the MB team. Thank you also to our funders. We've had many of them, our project collaborators, our scientific collaborators, our former team members, and our interns. And with that, I am going to stop sharing my screen and take a few questions in the remaining time that we have. So thank you all for listening.
Thanks, everybody. So we have a few minutes for questions, and we got quite a few, so we'll try to cycle through as many as we can. So one of the first questions we got was, while home visiting programs exist in every state, have you observed any geographic disparities either by region of the or within individual states, like rural versus urban?
In terms of the existence of home visiting programs, not really. I mean, I think they are, represented, across the country. There is a home visiting yearbook that actually shows, the number of programs and the number of clients served in different states. And, while there are differences, I don't think that there are vast differences. So it's not like there is a paucity of home visiting programs serving rural areas.
Okay. Some questions about virtual meetings, whether there's possibilities or feasibility of offering like iPads or internet access or electricity vouchers to use Zoom or any other digital format, and just like virtual group visits during COVID.
Yeah, Erin or Jaime, do you want to talk maybe a little bit about some of the things that we're seeing sites doing in that virtual space?
Yeah, I'd be happy to share. I know that some programs are dedicating resources to ensuring that their clients have an ability to communicate with them, doing virtual sessions, virtual services. So I have seen some that are signing out iPads or providing a hotspot, or even sending out headphones so that if they're doing a group, that it's not audible to other people in the home. So that's certainly an issue. It remains an issue in some areas where access to strong Wi-Fi signal remains a challenge. So the folks we've been working with in South Dakota, for example, virtual visits have not worked well there. So that's certainly something that programs are thinking about in being able to dedicate some of their resources to making sure that that's feasible.
How did the home visitors respond to changing their roles to include the MB intervention?
Yeah, I mean, I think in general, and this is not something that we touched on explicitly, I think home visiting programs and home visitors are really interested in getting sort of new tools and a new language to talk about mental health with their clients. I think there is a little bit of training around mental health that occurs for home visitors when they are hired, but it is typically not enough to meet the mental health needs of their families. So I actually think it's been a very positive experience. I mean, of course, there are some home visitors that push back a little bit, but I do think that home visitors in general are really, responsive and have an appetite for getting more training and more resources to address mental health.
So one participant is wondering if you can discuss, she's referring to the program, says it's derived from both CBT and attachment theory. And while you discussed a lot of the CBT today, whether or not you can discuss how attachment theory has been integrated.
Yeah, thanks for that question. I'll maybe do it with an example. So if we think about the pleasant activities module, so pleasant activities, would be sort of a CBT module. We talk in there about you can do pleasant activities by yourself, you can do pleasant activities with your child, right? So we try to sort of integrate in that way that sort of parent-child interaction could be strengthened by some of the pleasant activities that you'd be doing. So I think that's how we're trying to integrate the attachment concepts, like that throughout the curriculum. Again, that's just one example.
Right. Well, we ran out of time. We couldn't get to all the questions, but we really appreciate those questions. In the chat, I just posted the Mothers and Babies Gmail account. So if anybody wants to directly reach out to the team to ask their questions, they can use that, that email address. Next week, our webinar is Beyond Detention, New Findings from the Northwestern Juvenile Project. And you can find the link to the registration page on the IPHAM website. And I just want to thank the Mothers and Babies team for giving up their time today and giving such a great presentation. We really appreciate it. Thank you so much. And thanks to NUCATS too for co-sponsoring this event.
Thank you all.
Thanks.
Thank you.